There are some suggestions that some inflammatory bowel diseases we can improve with fecal transplant. One of the interesting things, and you're alluding to this, sometimes, for example, you can actually transplant obesity from a donor to the recipient. And so you could have someone who is very skinny, and now you do a fecal transplant, and now that patient not only gets cured of their C. diff, but they could gain 20 pounds.
Welcome to Target Cancer Podcast. Today I'm super excited because we're going to talk about the gut microbiome and how it relates to possibly cancers and inflammation and basically all the things that people have been wanting to know but have a lot of trouble finding, including myself. And I couldn't be more excited about having Dr. Sandip Patel from UC San Diego, where he is a professor of oncology, to talk to us about those things. I met Dr. Patel when we were both filming for a news piece, I believe for CNBC. Is that right, Dr. Patel? And I just thought you were so cool.
Well, likewise, and so it's great to meet you, great to join you. And if it's okay, maybe we go by first name basis. I feel I know you that
Yes, I would
well.
love that. I appreciate that too. I saw you when I walked in. You were filming your part, and I was like, oh, like who's this guy? You know, whatever. Didn't get to listen. You came out, and you just started speaking, and you just started sharing all these things about like engineered foods and how kind of, you know, they're actually edible and proteins. And I think I learned about that and Einstein and relativity all within 30 seconds. And I was just fascinated. So I was like, can you please be on my podcast?
Though with all due respect, I think John Hood actually gave us the time relativity talk. So I want to give credit where credit's due. Brilliant.
That's true.
Brilliant
It was three wise men in that building. Well, two wise men and then me. But today, hopefully we have time to talk about those things. But the reason I was really excited is because a lot of people want to know, and especially on my social media, I've seen it a lot. What and how does what you eat play a role, of course, into cancer? And we've talked about some of those things like in the past with red meats and things like that. But really this microbiome concept and all the really kind of, exciting and curious literature about that axis between like the microbiome and the gut and the brain. And we know if you get butterflies, like I had to, get on this call with you, which is a visceral reaction, like why do you have an emotional trigger that actually has something in the GI-ish realm? And I think that, that's a really interesting place to start, but then also how it goes backwards. So if obviously emotions can bring things that give you this visceral reaction, my stomach's tied up in knots, then are there properties about the gut health that can also go backwards when it comes to neuropsychiatric stuff or inflammation or cancer? First of all, how do you know about these things? Because I know you do like precision therapy trials and all kinds of cancer treatments. Like, how did you come to that?
Well, I think it's a great question. And so I think the key concept is, are bugs potentially drugs, right? And so we have as many bacteria in our body as we do cells, right? And most of the bacteria reside in the gut. Bacteria can also reside elsewhere. It resides in the lungs. These can be protective. They can cause disease. As doctors, one of the most common bacterial illnesses we get after an antibiotic that we have to deal with is C. difficile colitis, for example. That's a microbiome issue. Also, patients with autoimmune colon diseases. Sometimes you can actually do a fecal transplant. And the goal with that isn't to, gross out the resident who's doing it or gross out the patient. It's to actually give good bacteria. And so the idea that the bugs that live within us form a community that can either help prevent disease, or some bugs maybe from a bad neighborhood can cause disease such as cancer, and how we can understand how to make these changes in those bacteria so they can help us with human health, I think is one of the really interesting areas medicine has taken. And what can we do in our own livelihoods, our own diet, and even probiotic and prebiotic strategies to make sure we optimize gut health, I think is really one of the areas of medicine I'm most keen on. We're starting to see this in GI health. We're actually, as you nicely summarized, seeing it in cancer. There are actually bacteria that have been found around pancreatic cancers, one of the most common aggressive tumor types we have to fight, that actually eat up all the chemotherapy that you give. And so it's the worst case scenario. So you give a drug like gemcitabine, for example, which is a chemotherapy, and the patient gets all the side effects of that. And the bacteria, right before the chemotherapy hits the pancreatic cancer cells, chews up all the chemotherapy, makes it inert. So it's the worst case scenario, getting all the side effects without the benefit. And so can you actually take out those bacteria? Can you replace them with bacteria that maybe augment your immune response against the cancer? These are the types of things we're trying to investigate and better understand so we can think of bugs as helpful drugs.
That is absolutely wild. I had a pretty comprehensive talk with Siddhartha Mukherjee of Emperor Maladies, and we really got into how pancreatic cancer is, can really hone away or basically block off treatments and basically hijacks a lot of your normal cells, the extracellular matrix, all these things. I did not know that bacteria was yet another mechanism by the delivery being compromised. I don't know, is that something that's mediated in some weird way by the pancreatic cancer, or is it just an incidental thing that the bacteria happens to be around?
Yeah, it's a great question. I mean, in the same way, right, you learn in your biology textbooks in elementary school, right, you have fungus associated with the trees, right, the tree roots, and they kind of have a symbiotic relationship, right? Did the cancer and these bad bacteria that chew up the chemo create a symbiosis, right? And what was the kind of initial event for that? We don't know. But the idea that at some point, right, there were bacteria that were selected to grow around the cancer that, like the tree roots of pancreatic cancer, and in so doing, actually facilitate the cancer's growth is really an area that we're trying to better understand. This can happen in other tumor types as well. It's not just pancreatic cancer. It could be in lung cancer, breast cancer, skin cancers. And it's not just a cancer story. You mentioned earlier, Sanjay, really nicely, that from some neuroinflammatory diseases, for example, multiple sclerosis, one of the associations, and it may be a bit controversial, but it's that folks who do a lot of gardening are less likely to get multiple sclerosis. And it's not the actual shoveling or, getting pricked by a rose. It's that there's actually bacteria in the soil, right? And do those bacteria get introduced? That's a theory, right? We don't have a lot of evidence for it. But is it the bacteria that you're exposed to that allow you to not have that bad inflammation? We know this a bit from some of the research that's gone on in asthma and allergies. And so there's this famous immunology hypothesis called the hygiene hypothesis. And what it means is we grew up surrounded by bacteria rolling in dirt. Maybe, my kids did that this morning, right? And we were exposed to a lot of pathogens, a lot of worms, things like that before we had sanitation. And our immune system was used to reacting to those foreign pathogens, right? And it was trained to do that over millennia, right? But then over time, we've cleaned everything up. Everything has become sterile, right? And that's good. It helps us with human health. But now the immune system is hyperactive, right? It doesn't know what's foreign, right? And so does this lead to us getting more allergies, more asthma? Because now our immune systems interpret other normal proteins as what we used to have been, from an immunologic subset that have been weighted towards, fighting bacteria and fungi and proteasomes and helminths and things like that. So could it be that we need to be exposed to certain bacterial communities to avoid autoimmune inflammation as well? And so this is a whole kind of new world. This is kind of the dark matter of our own biology.
Interesting. So, in a sense, you're saying like you have all the troops, all the army, and they're all, over evolution, they've been conditioned to have to serve a role or purpose. And it's kind of that thing, at least we say in the South, you get too many, guys in a bar, too many men in one place and restless and not enough to do, then trouble, that's where trouble can happen. So it may be, in a sense, that, I remember my mom, sometimes on day 2 of summer, I'm watching Arthur, which is still semi-educational, and she's like, oh, we got to stop this, an idle brain is the devil's workshop, and so she would always stay productive. But to your point, when you don't have this propagation to basically recognize something, we know that sometimes your threshold theoretically can be a little lower to seek something out. It's almost like you're overhyped and over-prepared and over-ready. And then sometimes that thing, if it didn't come from a bacteria or fungus, can be something that just looks just enough like it to this thing that's just sitting there super excited. They're not getting lazy, they've just been at bay, and then they just go down this cascade of now having an autoimmune, property to attack things. And that's a very interesting concept. There's so much to unpack here. I'm just I'm trying to triage it all. Because at the beginning, and you touched on it again, you talked about stool transplants. And we know that you do stool transplants with refractory C. diff, right? It's just seeded it so much that no matter what you do, you just can't make it go away. It's no, I got my stake in the ground, and this is where I'm at. So you're just all right, we just got to, basically fumigate the entire garden and just reseed it with somebody else's stool in this setting. But I've heard too, not just to recolonize and kind of just redo of everything of sorts, that even in those circumstances that you were talking about, of maybe increased allergies, increased sinusitis, I've read places that doing a stool transplant, interestingly enough, can actually make that stuff better. Chronic allergies, at least, is theorized to be better with stool transplant, which kind of fits with what you were saying on saying okay, your body got too excited, let's just change the, again, fumigate the garden and just change the script. And so my first question is that a thing? And then if you want to take it to a second level, does maybe even doing a stool transplant, has there been any evidence or test to see that it may help with neuropsychiatric stress or these like kind of unknown moans and groans and pains that say, oh, it's all in your head, but it's not, and it really, maybe it's an inflammatory disorder, and that those can get relieved with the stool transplant. Because that, to me, right there, if you're somebody that's like, oh, I don't believe that bacteria, like right there, I mean, that's just studies that tell you that these very real objective processes got reversed just by having, a total change to the bacteria kind of, growth or what exists.
Absolutely. So great questions. I think the most we know for sure is we can improve C. difficile colitis, right, with a fecal transplant. There are some suggestions that some inflammatory bowel diseases we can improve with fecal transplant. But one of the interesting things, and you're alluding to this, is let's say you do a fecal transplant. Sometimes, for example, you can actually transplant obesity from a donor to the recipient. And so you could have someone who is very skinny, and now you do a fecal transplant, and now that patient not only gets cured of their C. diff, but they could gain 20 pounds. And so it turns out a lot of things we attribute to just host, just our DNA, just what we eat, may actually relate to the bugs that are in us, right? And it makes a lot of sense if you think about it, especially for gut-directed issues, right? Could it be that the type of bacteria that you harbor make you more likely to, crave sweets or crave X or Y or Z? And the fact that even sometimes in the process of these stool transplants, you can actually transplant autoimmune diseases like you're mentioning, theoretically, or even things like obesity, which are multifactorial, I think are really interesting. These are case reports and no one's quite sure, but it's plausible. And so I think we are fiddling. It's more than just transplanting the stool, right? You're transplanting a whole ecosystem, right? And sometimes, when you format the hard drive, right, it's you can get things you don't expect, right? And you're starting from scratch and you're replacing what you had with something that's new. This happens in bone marrow transplants all the time. That's the transplant I think a lot of us are more familiar with in oncology, but also organ transplants, right? In which you need to have immunosuppression and things like that because you're affecting the immune response. And so stool transplants can make a big difference in a positive impact, but they can have unknown impacts as well. And that's why it's important to study these for not only the diseases we know there's an impact, but also other diseases, because you can transplant things you do not intend to transplant. You could actually potentially make things worse. And it's because right now we just you transfer everything over. Right? There's no selection. There's no picking of the good bacteria, removing the bad bacteria. We're not there yet. And so if you're just transplanting everything, you're transplanting everything.
Right. It's like the card games where you can swap one card and keep the rest, or you have to basically table your whole hand and have a new one. Not necessarily that's a gamble because you got to take all of it at once. And the ideal thing is to learn more and be able to have different pieces. I'm just so fascinated listening to you. I literally don't know where to start, but or to continue to unpack. But I guess my next question is, one of the most common things that I hear with patients, whether they have cancer or not, or treatment or not, is I got sick, I ended up getting some antibiotics, and I swear, ever since, I just haven't been the same or felt the same. Oh, did you have some viral, some gastroenteritis, whatever? Yeah, but I'm not sure if it was viral or if it's antibiotic. There is evidence, right, that sometimes even just that an antibiotic course, or possibly, I guess, a virus too, but the antibiotic course, those people asking, could that have kind of changed something in my environment? It sounds like the answer is, that is absolutely plausible. That if you're told that it is impossible, that if you had any GI stuff after an antibiotic course, and especially long one, it is incorrect to say it's impossible that may be the kind of introduction or nidus into what maybe could have facilitated there afterward.
No, absolutely. And so the idea that antibiotics are a crude instrument, right, against, you're trying to fight a specific bacteria, but you get a lot of friendly fire. Right. And thinking even about, probiotics and prebiotics, these are all crude instruments. They're not as refined as we would like. And so one of the issues, and one of the important things is antibiotics save lives. If you need an antibiotic because you're really sick, the benefit is worth the potential risk, right? But the idea that, sometimes you could end up with things lingering. C. difficile colitis, right, is a classic example. You take out all the bacteria that ideally are bad, but you also take out some of the bacteria that may have been controlling the C. diff, and then it propagates, and then you get the syndrome, right? And so I think, a lot of this is post-viral or post-bacterial syndromes, right? Inflammatory, and you're recovering. But there's no doubt that, in my mind, that there's probably some contribution from the friendly fire and losing some of those bacteria that actually are protecting of you. We know this, right, from gynecologic health, right? Yeast infections, right, often happen after antibiotics. And it's because you disturb that natural balance. And, people talk about, yeast and, cranberry juice and things like that, right? That can help you. Yogurts, things like that. And so I think these things are very complex systems that we're distilling down into, oh, well, it's a stool transplant, or, oh, it's an antibiotic strategy. But the idea is, we're not that nuanced at it yet. The idea is we want to get there so we can be more precise in targeting specific bad bacteria while allowing the good bacteria to help you, do the things that you need to do.
No doubt. And to that same point, it's a very good question now that I do get with my cancer patients and those on treatment. When we give what's called cytotoxic therapy, right, multi-agent, so it really knocks down, it's attacking things that replicate the fastest, that's the strategy, but our bone marrow also replicates pretty darn fast, so then our white count falls, specifically our neutrophils. And so there's a lot of times when you sometimes have to give what's called empiric antibiotics or prophylactic even antibiotics. And prophylactic means I know your counts can be so low that I got to keep you out of trouble by just covering it. Now the question is, you have somebody that's somewhat immune compromised, and they have a cancer, and they're getting treatment. I've gotten a question a couple of times, and I love questions. Like I think it's like the key of life, right? And my patients know that, so they always come with them because I like to learn. What is the merit, and is it at least a reasonable concern that if you're on these prophylactic antibiotics, that you're also somehow like changing that protective layer to now possibly exploit something else in the process? And the main question that I'm asking, and I know there's no clear answer, or maybe there is, I don't know. If there is, then I'm going to start tomorrow. But should they be on probiotics? And I know that the data, again, like you said, and we should just say that nothing is binary, right? When I say probiotics, yes or no after antibiotics, even that is way too broad of a question. But like something like with empiric antibiotics, is there merit to it? And I guess what's the harm of trying if there isn't? Or is it equally harmful?
No, it's a great question, and I'm going to go back to a gardening analogy, if that's okay, because I think we'd all relate to it. So I think the step back is if someone needs prophylactic antibiotics, that means kind of at a population level, we know the risk of a severe infection, right, for someone with a low immune system. Maybe it's a hematologic malignancy, and oftentimes they're getting growth factor support, GCSF, things like that. Is so high that risk of fatal infection is worth a prophylactic antibiotic strategy. So I think one point is the benefit of these antibiotics is known.
You have to.
I think the flip side, though, is a probiotic doesn't mean all pro-good biota, right, or pro-bad biota. It's a mix, right? And so it's like if you took your garden, right, and you went straight to dirt, right, and you're planting seeds, you don't know, are there weeds in the seeds you're planting as well, right, that are going to cause issues? Is it all the seeds of the grass that you want? It's a mixture. And that's the thing with probiotics is it's not necessarily a pure mixture of the seeds of grass that you necessarily want. There's all sorts of weeds in there as well. And hopefully it's way more good seed than bad seed. And so that's one of the issues we fundamentally have is probiotics. Well, that's good, right? But pro just means more of, right? It could be good bacteria, bad bacteria, neutral. And I think that's one of the problems that we deal with. The other point is we introduce bacteria.
It doesn't factor in what yours is. Like that's the other thing that's like less than ideal. It's like in an ideal world, you would know what your population looks like and what the distribution is, and then tailor it. So one, it's pro, but two, that same pro cocktail may be good for someone else and not for somebody else. Like it's liabilities both ways.
Absolutely. Your normal bacteria where you feel good is probably different than mine. Right? It's probably different than someone else's, right? And so each of us probably have our own set point, right, on what that, just like we each probably have a morning routine, right? That's just ours, or an evening routine, right? And so it's very likely that, we have diets that reflect this. And so we probably have a normal state of bacteria, right? And then we're trying to treat everyone the same, right, with antibiotics, which are needed, or probiotics, which may have things that are not going to help you get back to your set point, right? And so that's why it's maybe not a one size fits all.
It's like putting everyone on the same diet plan or the same workout plan. It's like that's crazy. Like we know this plan works, but it's obviously needs to be tailored to you. On the notion though of like the morning routine, I'm curious. I created a big kind of storm on social media that I didn't realize, saying I take showers in the morning because you're crazy if you take it at night. And then there was a whole bunch of night showers and like it's gross, you don't take it in the morning. What are you? Are you a morning or night?
I take a shower at least in the morning, but depending on what I do, I may take one at night as well. But
I hear it's bad for your flora and bacteria and microbiome of your skin to take showers twice a day. Is that true?
I would hope not, but I think
looking at your skin, I think
worth
that's
the risk.
Yeah, there you go. Exactly. Clearly false. This is evidence. So So I interrupted you before your second point. So that was one point you said about not knowing the gloves. It's not a glove fit all and all that stuff. And then what was the second half of that, if you can recall?
Yeah, it really relates to diet, right? So the question I get most often from my patients, right, is what can I do differently with my cancer diagnosis, either in terms of exertion, which my answer is your body will tell you, do as much as you feel right, get your heart rate up, but don't overdo it, right? Don't be lightheaded, don't feel like you're going to fall. And then what to do with my diet, right? And that's a two-part question. One is, does the sugar fuel the cancer, which is a topic in and of itself? And two is, what does my diet do to the microbiome, right? So one interesting thing, there's a big hematology conference called ASH. And I was taught when I was training, and Sanjay, you were taught when you're training, well, order the neutropenic diet for all your patients. It's a diet that has low bacteria in it. And I think a lot of us, I never really bought it because I'm like, you're going to go outside in like a week and you're going to suddenly have all this bacteria. I'm not so sure that, restricting your diet, now, and are we reducing your calories and you use fresh fruits and things like that, which I actually think are fine, makes a lot of sense. But that was, the dogma, right? And there was a really nice trial that was done that was just presented this month that showed you don't need to do a neutropenic diet, right?
Huh.
And so what I've learned is I think we oversteer in medicine on diets. I think maybe low salt and low volume for the cardiovascular patients, or maybe in a nephrology diet, low FOS makes sense. But I think in oncology, we way overdo
So the
dietary
whole
restrictions,
cooked
I think, to
meat
the detriment of
thing,
patients.
yeah, it has to be cooked through. You can't have fresh fruit or fresh
Yeah.
vegetables. That's all. That was debunked.
We don't need that anymore. I think many of us kind of felt we never needed it in the first place, right? But yeah, no, you don't need that anymore, which is great because now patients can eat what they want, which is important because when you're going through arguably the toughest point in your life with the toughest treatment you've probably ever gotten, the ability to eat the things that you want, there's comfort in that food, right? It's comfort food, right? And so the ability to not have to feel like, oh, I don't want that apple or I can't do this. Now that's off the plate.
Heard
And
it
I
here
think
first,
that's
ladies
good.
and gentlemen. That is an order that you can delete off the EMR when
Yeah.
it comes to like the oncology admissions. That
Oncology diet should just be whatever the patient wants, in my
I
opinion.
love
That should be
that.
the only order in the EMR.
I always felt a little guilty about saying that it's just a peon, fellow or like out recently. Like I think it's fine, like because that's excellent. It's a huge pro there. I want to back up for a second because I was thinking about it as you were speaking, and you said, basically how the one that really hit me was like you can actually transplant obesity with bacteria, and how we talked about how they're all, unique constellations. But we also talked about how at the end of the day, they're organisms that have just hung around, much like cockroaches, I'm told, that just survived forever. Like in the same way, they've just kind of been here and coexisting with that fungus root example. When someone is born, and I don't know what made me think about this, but when you look at certain demographics or certain cultures or races or whatever it is, you're like, oh, those people are generally this size or this way, and some people are generally this, that, and the other. Which, of course, there's genetic part of it. There's no question. But when it relates to GI specifically, how much? And I don't know if this question is answerable, but how much of it is a genetic reason for the constellation or diversity of your microbiome in your gut, and how much of it is actually just the household you're in, the house, the city, and everything, and like is 99% of what your GI constituents, which we're saying can lead to obesity and neuropsychiatric stress and all these other things, is it 99% of the stuff that just really has to do with your environment? Not in the nature nurture sense, but now of actually the GI stuff? Or is there a percentage that's actually like predisposed for what your gut environment's going to look like, if that makes sense?
No, absolutely. And I think, sadly, too many questions in medicine are what are called multifactorial. There's so many different factors in complex systems. But to add even one more wrinkle, we know that folks, like when you're born, right, from mom, if you have a vaginal delivery versus a C-section, the microbiome is completely different because
Right.
your route of exit as an infant is different, right?
Like you've already
And
started
then
to see
also,
it. Yeah.
exactly, and then even breastfeeding itself, right, introduces some of the initial microbiota, right? And so if you're, formula versus breast, things like that, all these may have effects, right? We
See,
don't
I
know
still
good,
consider
bad, or
all that.
neutral.
Yeah, I still consider all that environmental. Like, is there something actually like polymorphism wise or genetically that is secreted from the gastric or intestinal contents that will influence the things that you are exposed to? Or is it basically just you know, you got what you got? Like, really, that doesn't play much of it, and it's so much more of the moment that what bacteria did you get, C section or not? Like, is it pretty much all that? Or is there something that's actually being I guess, synthesize the peptide or protein
Yeah.
that also influences? I don't know if
No,
there's
it's a
an
great
answer.
question, and it's not a question we have an answer to, right? Could it be that if you have a certain HLA type, you're more likely to
Right.
have a certain predisposition towards certain bacteria versus
Exactly.
others? That we don't know, but we do know that how you're born, how you're fed, right? Those initial moments in your life have huge impacts on your microbiome, and then of course, as you go on, right? You get antibiotics every month, right? Or did you not have any ear infections? You had no antibiotics. All these things matter, right? Who you play with, are you playing in the dirt, right? Are you getting exposed to infections early? And then, depending on what you get exposed to, are you more or less likely to get autoimmune conditions, right? And so these are all questions, folks are looking at. There are no clear answers, but a lot of this is not kind of wired in your DNA, right? Which is at the moment of conception. It may be wired, epigenetically, so to speak, or bacterially, secondarily at the time of your birth and exit right into this world.
And that's what's kind of blowing my mind. Like I always thought about until I had kids, I always thought nurture was like 99%. I was like nature, but nurture matters. And then I have kids, and I'm like they're totally different. And obviously they were in the same household, and one's extremely driven, and the other one's like they're just like a personality is crazy. So I'm like, okay, there's way more nature than I realized. But what's kind of blowing my mind, and I'm trying to basically like sink my teeth into it philosophically, is when we say nurture, this podcast is telling me nurture doesn't just mean the way I thought about it, like imprinting, like duck follows mom, and you know what your parents do, you know how they eat, their proportions. That's why that generally there's obesity in some places and not in others, is because of the cultural aspect. But really, there's a whole nother element that's arguably, conceivably, even more influential, and that's the nurture in the sense of nothing from your mom or dad, but just the environmental, what has gone through your nasal cavity, and what has decided and how to just all of a sudden flourish down the hill. It's like when you plant azaleas, you don't know exactly what color they're going to be and all that stuff. Like that is a nurture squared, which is a very interesting concept, and I'm sure once that can of worms, if you will, has been opened, now you're going to look at regions and like air, like how much the humidity is thinner here, and these things can't survive, but here they can, and these funguses don't. I mean, you could just start dissecting like crazy what someone is exposed to where in the world, and how that may influences. They only have a 7% body fat. They have a 27% in the same diet. My mind's getting blown right now to think about how many things that that can be played around with, I guess, with that concept. To your point about antibiotics, I saw a study, and forgive me for not knowing the total degree of merit for it, but something, and it sounded kind of wild, was that they split people that had antibiotics in their lifetime, and it was like less than 3 to 5 times or never, between like 5 to 15, and then above 15, and their effects on the chance of cancer. Have you heard that? And basically it said that in that if you had antibiotics, but you were in a category of like less than 10, if I'm not mistaken, it said it was like twice as likely to have cancer. Was that just the way the numbers fell, or can you tell
Yeah,
us
I
about
think
it?
a lot of time with these retrospective studies, right, especially when you're making kind of big
Yeah,
cutoffs, it's just hard to interpret. I think and also the question is, what's the actionability? What can we tell folks to do with that data,
and
right?
that's why I didn't like the study, because it really
Yeah,
like it really
and
could
so
do a
my
really
point is the point I make to my cancer patients, which is we have to control what we can control, right?
yeah.
And what we can't control is if we have a severe infection, we do antibiotics. We don't do it willy nilly, right? We do testing. We give appropriate use antibiotics for those patients who need it, and that's the right thing anyway, because we want to prevent resistance not only for them but for other patients, right, as well, down the line. And then also what we control with our diet, which I think increasingly is really eat what you want. Even the sugar drives cancer hypothesis has gone 720 degrees, right? And if sugar did drive cancer, we would have a coincident epidemic of diabetics, right, with cancer, and we just don't see that. I mean, in some cancer types, diabetes is a predisposing factor, and high sugar may be. But as a general rule, eating that, one candy bar or something like that is not going to make the difference, right?
Let
One
me
way or the
just
other.
drive that home, what you said. You said, obviously, I think anyone can understand this. That's maybe not in research like you are, and certainly you are more than me. If eating sugar was as strong of a corollary to that's what causes cancer, then you're saying that you would see lines that more or less were congruent on, okay, causes pancreatic cancer. Then diabetics should have just an equal amount of pancreatic cancer, and that the people with pancreatic cancer should never be ones that are eating much sugar, like that are only eating much sugar. And you're telling me they are not like in any like solid way like mirrored, correct?
Correct. Yeah, it's a very minor association for certain cancer
Loose,
types,
loose.
but it's a lifelong history of it, right? And oftentimes when we see our patients, like I said, they're at the roughest time of their lives. They have certain foods that may still be appetizing to them, right? If they're getting chemotherapy, there may be certain things that just really are the only things they want to eat. And I think what we've learned either from this neutropenia study, neutropenic diet study, or really, frankly, the more data we get, is that all these exotic restrictive diets are not doing anyone any favors. And we're probably facilitating cachexia or weight loss by not letting folks kind of eat what they want, especially when their taste is affected, especially when they're feeling a little down, maybe from the treatment. And so my view is we want to support the patient with the kinds of foods that make them, feel better, make them feel happy. And calories in food form are the best way of getting it.
It almost sounds like you're saying, and I think I have shared, I feel this way now. If somebody were to ask me, that it's almost like a more humbling look or opinion on what we're eating. That it was audacious, brazen, and usually those terms have to do with ignorant. It was usually like audacious, brazen, due to ignorance, irreverent almost to say like this is how we're gonna. It's this easy, and this is what you should and shouldn't do, and this is what's gonna happen. Like we've learned. Like they always say in the old adages, the more you learn, the wiser you become, the more you realize you don't know. We've learned that it is way more complicated than these kind of decades long, very kind of simple one-dimensional thoughts and ideas we had. If we've learned anything, we learned that that is probably most obtusely the wrong way to do it. And so we should at least withdraw those kind of like, things because we know enough to know that it's way more complicated. And with that, also, that in general, balance and having just kind of like the number of calories and things that are natural is probably more. You just err on the side of nature and what is natural if you're unsure. Is that correct?
You nailed it. I think all things in moderation. And I think we oversteer. I think we're over prescriptive on diets. And I get it as a patient. That's something I can control. So I wouldn't mind actually getting a prescription for a particular diet because that gives me control back.
Right.
But I think if we put that energy into, aerobic exercise or something like that, because we all have a finite amount of willpower in a day, especially if we're going through something harsh, right? Like our patients are. Maybe we don't need to be so strict about the diets, right? As long as we're meeting a certain calorie count and we know protein is probably better than carbs and we want to hit a certain calorie number. And then we use that ounce of willpower, whatever unit of willpower there is, on a little more aerobic exercise. Maybe we're all better off, right?
Yeah.
But I think things in moderation and understanding that sometimes we oversteer on these things. It's humbling, right? Because you and I have probably been ordering neutropenic diets for how many years, right? And we thought we were protecting the patients. We really did. We thought we were protecting you from an infection, and we weren't. We were just depriving folks of the apple that they want or the fruit that they want, when maybe that was one of the few things they could taste, right?
One of the most depressing things, and I know, you probably have seen this, is when somebody is facing a truly just incurable for now. Like I would say the longer we live, like who knows what will come out, but like even in your lifetime, if I can control the disease. But if it's a true incurable stage 4 setting, the amount of pressure I am seeing sometimes, and especially in the comments that come from others that, maybe it's naive, but I believe just care. They don't realize like what it may do in stress and in almost like kind of attenuating how maximally somebody can live to say, you need to do this, right? You shouldn't have sugar, it's bad for you, right? You should whatever. And you are very like just edified and gifted, and I honestly have so much respect and admiration for you, especially after learning all the things you did after I met you. I probably would have been more nervous. But you are saying, and that's exactly what I've read, so I'm making sure we're congruent, that if we had learned one thing in medicine and oncology, and especially like to the comments, well, there's no money in it. It's been studied. It's not that it hasn't been studied because, it's not profitable. We have learned, if we've learned one thing, is it's way more complicated. That it would be more erroneous or incorrect to say it's so one-dimensionally modifiable that would be steering you in the wrong direction. It's not that we don't know, so we're not commenting. It's like, we know you probably shouldn't avoid sugar. Like, we know that or certain food types. And I hope anyone listening to this that have felt that pressure, and really, and I mean this, like in a gentle way, but if you're listening to this and doing this because you mean the most and want to do the most, like that's that humility part. It's like we're trying to learn, but I hope just in hearing this, they hear it's way more complicated, and the stress of trying to do that may be more challenging. Whereas cardiovascular fitness, aerobic exercise, bone strengthening stuff, we know what that does for happiness, decreased stress, libido, enjoy sex life, stage 4. I still want my patients to do all the things they enjoy, and those things I know for a fact help them. And and maybe, I shouldn't say this out loud, but sometimes if they want a glass of wine, well, all the doctors told me not to. I'm like, dude, it's your anniversary, have a glass of wine. Those things are just so important, and we know the things we know, which are those are the things that help stress, and ultimately the thing that's the best for emotional health. There's nothing more valuable, because we're all finite and have little blocks, right? So that's a very important point, and I'm glad you shared that. With all that said, before you said that, I was wondering, because I'm just so hung up at the beginning, this whole pancreatic cancer has bacteria that's literally eating up the facilitation of a chemotherapy we know that goes in there, and you said it's other tumor types. Before you said that about how difficult it is to monopolize and puppeteer the bacterial microbiome, and especially around the tumor, is there someone whose ears perked up, who has a loved one that they really care about, or they themselves have cancer? Tell me more about that. What can we tell them to say, because at first I was going to say, well, how do they do that if they want to go an extra level? And I know the answer is it's not that clear. But how is this being studied? Is it being injected around the tumor to maybe kind of suck in the chemos? What can someone do if they're interested in trying to explore that kind of theory or evidence?
Well, I think we don't know the biologic effect of this. This is something that's been observed. It doesn't mean that the dose we give, it doesn't mean it goes to 0%, right?
Oh, yeah.
And so I think, the standard dosing, we know clinically what happens with patients. So by no means to
No. And nobody's going to be able to
that.
test anyway. I wouldn't know where to take you to see if you had that bacteria. So
and so we don't have that testing
Right.
yet. But the idea that not only we could, but could we flip the bacteria, right, into actually, helping out fight the cancer, right? Is a different species? Can you engineer bacteria? Can you make bugs as drugs? I think all these are really key. I think, one of the key concepts is anytime we're treating a cancer patient, we want them to get back to their normal, right? What their normalcy is, right? And I think a lot of what we do ritualistically is doubling down on abnormalcy, right? Abnormal diets, abnormal restrictions on exercise, restricting travel, things like that, where there may or may not be a great reason to do so. And for me, I think the more I've learned, it's humbling, right? It's actually every time we've had a study that investigates changing someone's natural behavior versus retaining their natural behavior, it turns out there's no difference. And so why not let folks who are in the toughest time of their life be the people who they are?
I just love my heart is getting full listening, because it has to be one of the reasons we almost celestial winds got along right off the bat, because I feel the same exact way. A lot of social media, I am not the doctor, and I don't support doctors that just kind of bash or invalidate things, right? Most anything that circulates that may seem incorrect on the surface comes, I believe, again, maybe naively, to some degree of truth, and that needs to be explored first and validated. And so there's a lot of opinion. I like to go natural, which means I want to be free of intervention. And there's definitely a role and a place for that. And if somebody was saying that 10 years ago, maybe they were would have been more correct than doing a restrictive diet. It's the same reason I teach my residents and med students and everything. I'm you don't just go willy-nilly giving diuretics just oh, you have a little edema, because our kidneys are super smart. And if they're working, I'm messing up something that has a huge cascade of events, right? And it's the same way with testosterone. I have my own opinions, but that too, there's a very delicate cascade there. So I want anyone that does feel a little reserved or hesitance towards modern medicine to feel seen or be heard. We are both sharing, you and I, that there are things that we have been active rather than passive, that we were sure in medicine, we're oh, it works. But if you're hearing that, one, you're validated, right? And two, in us being humbled and learning, we are learning to be more passive, because we realize that sense of normalcy, or let it do what it do, as the kids say, is actually probably a really good thing. And so what we're doing is we're tailoring our interventions and trying to remove less is more. That's the concept, I guess, of what I'm trying to say.
Sometimes
And
more is less.
Exactly. More is less, and that's what we're realizing that you're putting a strain on something that's otherwise natural and beautiful. And so I hope that's the kind of meat in the middle. Like, please, we validate the fact that these things like may have been like a little haphazard, but the more we've learned, we're more passive. But that doesn't mean obviously that there isn't a role for somebody with testosterone supplementation, like when it's needed during the cascade, or for like diuresis, etc.
And
But I think
everyone's normal is very likely to be different. And what that normal is and how to best honor it during a patient's journey with their cancer, I think is, that's the art of medicine.
yes, 100%. And that's such a beautiful note to end on, but I do want to ask you like two semi rapid fire questions. I don't even have the second one, but the first one is this: acid reflux medications, PPIs. Give me the 90, 120 second, all the questions I get about is it bad to be on it for over 4 to 6 weeks? Is it going to make me have more likely cancer? Is it going to what's, of course, it all is patient specific. What's your spiel?
No, it's a great question. And my view on PPIs is just like antibiotics. They're probably overused, right? And could there be some slightly detrimental consequences to overuse? Absolutely. But before we had PPIs, people would have big ulcers, they'd have, bleeding events. I mean, these are godsend drugs, just like antibiotics are. And so if you need them, you need them. We know if you take them long term, there are risks, in terms of osteoporosis and, different bacterial in the gut. We don't know the long term consequences of that. But if you have acid reflux that's uncontrolled, it's your best alternative, right? And so I think similar to antibiotics, PPIs, use them judiciously and wisely, but not haphazardly. And I think this goes back to the theme of this discussion, which is, everyone's normal is slightly different. And the more we deviate from that, we can create problems.
So you should it's reasonable to not want to be on it chronically, just indefinitely, if it wasn't for something ulcer, this and that, maybe gastritis, you're taking it. That's something that's reasonable. Go back to your doctor and say, hey, can we balance the merit of this? Is there any association with that of at least with cancer risk or that kind of stuff, or is it pretty much very loose?
Yeah, with the H2 blockers, there was a meta-analysis with one of them, and actually the one that's associated with it is pulled from the market, so you can't even get it if you wanted to. But broadly, and we're not even sure if that's a real association or not. So my general sense is they don't have a strong association with cancer. And, compared to the era when people were having, GI bleeds, right, and perforated ulcers, in the 80s, these are godsend drugs. But like most drugs, you got to use them appropriately. Otherwise, they can have, any drug that has an effect will have a side effect, right? That's just the nature of medicine. And some of the side effects, though they're minor, over a long period of time, could add up to a non-zero risk, though at least I haven't seen the cancer risk with PPIs. But, we've seen osteoporosis risk and things like that over time. So I think it's just a discussion to have with your doctor, and your normal may be different than my normal.
Yeah, I think that'll be the baseline, statement, not because it's a cop-out, because it's true. It's just everyone's normal is different. Rapid fire question number 2, if I may. Is there anything, and we did talk about pancreatic cancer and some amino acid restrictions with Dr. Siddhartha Mukherjee, but otherwise, is there anything that has a little bit tighter than just, floated theory, association of what you may or may not, it wouldn't hurt to eat more of when it relates to a cancer? And of course it's not going to be any cancer, but prostate. Is there anything off the top of your head where you're when they're looking at prostate, it seems like not having red meats, or bladder? Is there anything that an active either exclusion or an active introduction may have some merit or pan out in the next couple of years?
Yeah, no, it's a great question. I mean, there are some associations with, charred and fried fish, for example, and gastric cancer. Red meat and colon cancer, though that's a very subtle risk. The alcohol and liver cancer, right, and esophageal cancer. So I think.
What about the ones with cancer and getting treatment? Yeah. Is there anything that it looks like? Because I know some centers look at it incorporating. They're starting to actually add that along with medical marijuana. And I know people think we're not natural like modern medicine, but we are. What are some of the things being looked at, if you know of any, that when you have the cancer?
Yeah, so there doesn't seem to be any major dietary changes that tend to influence the cancer. There's some rare tumors like pancreatic neuroendocrine tumor. If it makes a certain hormone, you may want to have a certain diet, but that's 0.1% kind of thing. But for the vast majority of patients, the diet won't have a huge effect. Now, even phytoestrogens, right, for breast cancer, right, it's controversial. It's gone back and forth.
Really? Okay, good.
Yeah, and so I think the unfortunate answer is it's complicated. We don't have a great answer for it. And as time goes on, the answers may change. But for the most part, diet is really just about trying to maintain calorie counts. And if you want to have more protein than carb, that makes a lot of sense. Well, I'll ask my patients is you want to hit a calorie count. The more protein you use to get there, the better, right? And if you want to go low carb, that's great. But the choice should be you're doing more protein instead. Because if the choice is between nothing and carb, I'll pick carb any day of the week to hit your calorie count, to avoid
Exactly.
weight loss.
Exactly. I'm glad I just kind of almost like stupidly correct. Like these are all the things I've been saying, but of course you're the academician that like just knows troves of data. So I'm really glad that it's been supported. I'll like read it, think about it. I'm obviously evidence based, but the evidence is coming out so fast. I'm going to steal one more question if I may. I'm sorry, but we know when you look at things that are like Mediterranean diets, right, versus like olive oil rich diets versus like paleo diets in certain areas that are almost all grains and fruits because they can't mass produce things. Is there and I know there are multiple, I kind of know the answer to this question. By the way, anyone listening, I usually know somewhat the answer to a lot of questions I ask. Somebody asked me that the other day, like, you don't know anything. I'm like, I know what I'm asking, but like, obviously I want to tease it out. Which one of those diets, is there any of them that seems to have a strong correlation with a decreased incidence with a certain kind of cancer? Like I know the ones that do, fish and gastric, in Eastern Asia and all this stuff. But what's one that's like, that paleo or that fruit and grains or that olive diet, is there anything off the top of your head that kind of, fits or is associated?
Yeah, to the best of my knowledge, most of these are neutral. Now, I know the Mediterranean diet has actually really good cardiovascular outcomes. And some of this may be Mediterranean ancestry. There are these places called blue zones, right, where certain communities live. And it may be the diet is part of their wider kind of, dietary plan. And that's probably a component of it. But to my knowledge, paleo diet or Atkins diet or something like that doesn't have drastic effects on one's cancer risk. And so really, if your normal is I'm doing a paleo diet, and that's you, that's your normal, and you can keep doing it and keep doing it while you're getting your cancer treatment, if God forbid you have to do that. The key is maintaining the calorie counts and maintaining your normal.
Right.
And I think one of the things we've learned is the more we deviate from folks' normal, we're not actually helping as much as we think in our mind. We're actually probably causing issues.
But one thing I would say, I would argue, I'm not arguing because obviously there's not what you're talking about, but having an absent fiber diet, I think that is a cause for a lot of Americans now, like what they're normal, what we're used to. So that, of course, is a very unnatural. So to your point, it needs to be natural things like whatever. But anyone listening, if you're not eating stuff with stems or getting some fiber in some kind of way, it's like an all meat diet and all fast burning calories, that is going to increase your chance of colon cancer, right? Like, and that's something that somebody, if they're listening, can do pretty modifiably that will help them out. But obviously that wasn't the question I asked. So
no, but it's a good point that fiber is important, and a normal diet, right? The kinds of things our ancestors ate, right? Paleo or otherwise. Probably helps us. And so I think it's a great point that we want to stay true to ourselves, but also our kind of ancestry, right? In what we eat.
Oh, speaking of that, true to ourselves and ancestry, turmeric. Is the kind of debated evidence? I know inflammation needs to be higher doses, but on cancer and stuff, is that because of anti-inflammatory processes? As I understand it, they have a whole cascade of stuff that's anti-cytokine. It's not so much due to the gastric or microbiome, correct? It's more just the properties of turmeric itself.
Absolutely. If you're going to do turmeric, you're doing it because it's delicious, right?
Exactly.
You want it on your food. You shouldn't torture yourself with it. Is it an antioxidant? Sure. Is vitamin C an antioxidant? Absolutely, right? Linus Pauling thought it'd be the cure of all cancers, right? I wish it would make our infusion centers be a lot more easier for our patients, right? If all we had to do is give vitamin C to everybody and it melted tumors away, right? And so I think it can be part of a balanced diet. Is it going to have a meaningful impact? I don't know. Then you'd expect cancer incidence in India to be way less. And unfortunately, right, there is cancer in India, right? And so this kind of is the inverse of my diabetic analogy on sugar. And so if their effects are going to be very subtle, if your normal is eating turmeric, then by all means do it. But it's not a mandate. If you don't have to suffer through a turmeric meal if that's not you.
Yeah, 100%. Sandip, it has been such an absolute pleasure. I'm looking at the clock. I'm like, there's no way it's already been an hour. if anyone, like people like myself, want to just hear you speak, hear more, I know you're on the news a lot and doing media stuff and everything. Is there some focal, concentrated place that can actually be able to kind of learn from you and get your updates? Do you have a Twitter handle or especially
Yeah,
video?
absolutely. On Twitter, on Twitter, I'm at Patel Oncology, and on Mastodon, I'm at Sandip Sandip. And so, hope to interact with folks online, get their thoughts. We don't have all the answers, but sometimes we have a couple answers.
Excellent. Thank you so much, Sandeep. Anything else you want to leave us, or just be natural? That was your
Yeah,
message. Be natural and be more humble about like less intervention. Do what's normal, right?
absolutely. Marie Kondo our diets a bit, right?
Love it.